Good afternoon. My name is Dr. Clement Mnuka. I'm here again talking to you about this problem that I have in my clinic. The patient walks in and the patient is pregnant. And now I have to send this patient to the antenatal clinic. This is in government, right? I have to send this patient to antenatal clinic. The first thing the patient is offered at the antenatal clinic is counseling for HIV testing to find out whether the patient has got HIV or doesn't have HIV. The reason the people are so concerned about HIV infection is because there's the baby there, there's the mother, and there can be what is known as vertical transmission. In other words, the transmission from the mother to the baby. So that's a concern of the antenatal clinic. And the other concern of the antenatal clinic is this one. You know, the commonest maternal cause of death in South Africa are patients who are HIV infected. That's the maternal cause of death. It's the commonest in South Africa. And this is a problem. So, but the patient is sent then to the antenatal clinic, and the antenatal clinic will do what is known as a rapid test. They don't do the ELISA. Well, ELISA will be done only for confirmation purposes, but if the patient is there, the patient will be offered an a rapid test. And if the rapid test comes back positive for HIV, immediately that patient must be considered for pool blood for CD4 count. Why necessarily CD4 count? Yes, CD4 count, very important because you need to be able to classify the patient. Is this patient eligible for treatment or not? Right? If the patient is eligible for treatment, the patient will be sent immediately to the ARV unit, Antiretroviral clinic, where they are given the ARVs, the antiretroviral therapy. So the patient will be immediately sent there. But if the patient is not eligible for that, well, we will have to think of AZT as prophylactic therapy to make sure that there's no vertical transmission. AZT, but then before you think of AZT, you have got to take into account the fact that AZT suppresses the bone marrow. And so therefore, it's easy to get an anemia here. So what you are interested in as a monitoring doctor, as a monitoring healthcare worker, you're interested in the HB, hemoglobin. If the HB is greater than 8 grams per DL, that's powerful, that's very good. You can go on with your AZT. But if it's less than that, there are two things. Well. The easiest is to send the patient to the medical department for consideration of transfusion. They always give these intact cells. Right. So you can do that. Or you can, this is if the patient has got an HB of less than 8 grams per DL. That's very important to do, right? But the most important thing I'm worried about is this CD4 count. CD4 count, as we know, it's a surrogate marker for immunodeficiency. How immunodeficient is this patient in front of me who is pregnant, carrying a baby? That's a big problem. That's a problem I need to know the CD4 count, because if the CD4 count, for instance, is less than 100, and this patient is in government, oh, beautiful. If it's in government, there's no problem. There's no problem. Because if it's less than 100, oh, people in government, they always do what is known as a reflex test for cryptococcal meningitis. Cryptococcal antigen, just to find out. But when this patient is in private, that will have to be sanctioned by the doctor. The doctor has got to initiate that and make sure that this is done. Because you are it. Here's a mother who is HIV infected, who might be having cryptococcal encephalitis. Well, if the CD4 count is low, you expect that. This patient in front of me can have toxoplasma encephalitis. That is a possibility with low CD4 counts. And this patient in front of me can have HIV encephalopathy. That is a possibility if the CD4 count is low. This patient in front of me, can have a lymphoma. Well, the normal lymphoma with HIV infected patient is what is known as non-Hodgkin's lymphoma. Well, this is what these are your expectations, and you are worried about this. There are quite a number of opportunistic infections that you're worried about. That's why we say CD4 count is a surrogate marker of immunodeficiency. It's because we're worried about these opportunistic infections like pneumocystis jirovecii pneumonia. Oh no, that's a killer in HIV infected patients. Oh, let's give that baby a chance to live. Let's make sure that the patient is put on treatment. You know, this patient can develop toxoplasma. There's toxoplasma gondii, which can be, it's an opportunistic infection. Get toxoplasma encephalitis. If the CD4 count is low, you can get a polyoma virus. The virus known as JC virus. And this virus, in combination with HIV, it can cause what is known as PML. What is that? Progressive multifocal leukoencephalopathy. This is a mess for a patient who is caring, for a mother who is carrying a baby. Oh no, this is a mess. Demyelination of the white matter of the brain, giving rise to dementia, giving rise, altered mentation. Oh no, giving rise to what is known as cortical vision loss. Oh no, we have to make sure that the patient has got a decent CD4 count. We've got to make sure, because if the patient has a low CD4 count, we are worried about quite a number of things. like I say, progressive, multifocal leukoencephalopathy. This is not something that demyelination. You know the myelin sheath. Myelin sheath is what covers our nerve cells. Is what covers our brain. Our brain, white matter, gray matter is covered by myelin sheath. But even that is now removed. The presence of this opportunistic infection, polyoma virus, the JC virus, it demyelinates, it removes the myelin sheath, giving rise to this weakness, giving rise to this altered mentation, giving rise to what? To dementia, giving, there's nothing as bad as to forget even your own name. My name is Clement, and I would love to remember that all the time. But when I go to an extent of forgetting that's a mess. That's a mess. And that happens if you have got these opportunistic infections. And this is now happens to a patient who's actually pregnant. An onset of seizures, which you can't explain. With a patient who's pregnant, number one, we need to be able to explain, is this eclampsia? And, is this HIV encephalopathy? That's a confusion now. Is this toxoplasma encephalitis? Is this the presence of a lymphoma that causes this? Is it cryptococcal encephalitis? What is it that causes this onset? It's a new onset seizure. But this patient is pregnant. All I'm thinking about is eclampsia. Oh, I have to check my blood pressure. And, normally when the blood pressure goes high up in pregnancy, they get pre-eclampsia, they get eclampsia. And then when they get in eclampsia stage, they get into fits. Is it that? Or is it HIV encephalopathy? Or is it toxoplasmosis encephalopathy? Because those can cause seizures. What is the problem? This is the type of confusion that you are trying to solve. When you say, let's make sure that the CD4 count is done. CD4 count is done. We want to make sure that we want to exclude these. No, it is not HIV encephalopathy. Oh, no, it is not toxoplasma encephalitis. Oh, no, it's not a lymphoma. Oh, no, it's not cryptococcal or cryptococcal encephalopathy. We want to say that with all the confidence. Yes, we want to say there was pre-eclampsia, and so now it's eclampsia, because that explains it when a patient is pregnant. That is expected. But it can be, we can make sure that is controlled. I mean, people give a lot of things. They make sure that, the people in the ONG department, they make sure that they control that and all that. But from our side, we want to make sure that this is catered for. In other words, we exclude all this. We know HIV is a problem, in the sense that we will not be able to make out whether this is syphilitic meningitis. Is this patient having syphilis? The problem with HIV is that it's going to make sure that it's going to make it difficult to diagnose syphilis. This treponemal test that we trust so much, it reduces the sensitivity, or shall I say, you're unable. You say to a patient so confidently, you say, no, you don't have syphilis. You don't have syphilis. when the patient is actually having syphilis because of the reduction in or failure of the test to be recognized because of the presence of HIV. HIV reduces the sensitivity. So the test doesn't become sensitive anymore. You are able to say to a patient, no, you don't have syphilis, when the patient is actually having syphilis. That's the worst thing that you can do as a healthcare worker, to tell a patient that he is negative for, when, even with cryptococcal meningitis, you say the India ink, which often used, though that is why we say cryptococcal antigen is the best. The presence of cryptococcal antigen is the best to say that. I can say that with all the confidence. No, this is cryptococcal encephalitis or encephalopathy, because cryptococcal antigen, I got it as positive. But India ink can test negative. When it's supposed to be positive. It can test negative. Because of HIV. This is sad. In other words, it forces you as a healthcare worker to sort of, you're telling lies to the patient if you say the patient is negative when the patient is supposed to be positive. You're saying patient relax when the patient is not supposed to relax. Well, you as a healthcare worker, you're supposed to make sure that this patient, you don't relax, because, in other words, you're believing that when the India ink is testing negative, and you believe that, the high rates of negativity, of negative tests in syphilis is terrible. The high rate of relapses is terrible. The high rate of false negatives is terrible. The high rate of missing of the diagnosis, the high rate of even relapses is terrible. And this is because of HIV, the presence of HIV. So that is why it is crucially important that we say, this patient is pregnant, and when this patient is pregnant, let's make sure that we diagnose the patient correctly. And how do we do that? Well, we send the patient to the antenatal, and so that the patient can do the tests there. And if the tests are done, and we send the patient to the correct department, like medicine department of the patient, for initiation of or to a clinic, HIV clinic, where the treatment is going to be initiated if the patient is eligible for treatment right now. These are the things I'm trying to highlight, what HIV does to a normal condition. A normal condition like syphilis. The inability, the failure to diagnose this. You fail to diagnose it. And when you fail to diagnose it, what are you going to do as a healthcare worker? You are going to give the impression that the patient doesn't have the condition when the patient is actually having the condition. It's because of HIV infection that it is difficult to diagnose. The treponema tests that we know so much, that for an immunocompetent patient, the patient would have tested positive without any problem, but because of HIV, the patient does not test positive. I want to say thank you very much for listening to me, and I hope when you see a pregnant young lady, you are going to make sure that this patient is sent to antenatal clinic, and so that the patient is offered some counseling, and the patient is offered some HIV test to establish whether the patient is having HIV or not. If the patient has having HIV, you are going to rapidly ask for the CD4 count to be done because you're worried. You don't know. You can't place the patient. You must be able to place the patient. You must be able to say, danger zone, no danger zone. This is what I must do. This is what I must do. When do I consider my HIV encephalopathy? When do I consider my toxoplasma encephalopathy? When do I consider my cryptococcal encephalitis? When do I consider my lymphomas? Try to think of non-Hodgkin's lymphoma, which is most common. And this is all an attempt to make sure that we reduce this high rate of maternal deaths in South Africa. And if you jump for the CD4 count, you will know what to do. You will know what to do. You know, there are other tests that could help you. For instance, if you think, hey, no, I think this is toxoplasma gondii infection. So this is toxoplasmosis. This is toxoplasma encephalitis. There are nice tests that you can do. You check the antibody test. If there's IgG, then you know, toxoplasma. IgG antibodies, toxoplasma. Most of the time, toxoplasma. You know, these are some of the things that one has to sort of, you know, I'm excited to say that there are certain viruses which, like the polyoma virus, if you isolate that, polyoma virus, some people call it the JC virus, in the presence of HIV, that is a problem because it can cause the progressive multifocal leukoencephalopathy, which is an opportunistic infection. But if you jump for the CD4 count and you make sure that you know the CD4 count, you start treating the patient, you are trying to reduce the, shall I say, the infection by those opportunistic infections like pneumocystis, Jarovac pneumonia, the one which used to be called pneumocystis, Carini pneumonia, PCP, all that. Thank you very much. We'll keep on reminding you, and of course, this, once the patient is pregnant, it's a good, and the patient is HIV positive. Patient is tested positive for HIV. It's a good. It's a powerful idea to check for cancer of the cervix, because with HIV, the cancer of the cervix, the cancer of the cervix is well controlled by the suppressor. The tumor suppressor proteins. Tumor suppressor proteins are able to suppress. They're responsible for the regression of this infection. It's an infection by human papilloma virus to cause the actual cancer of the cervix. But then you're able to regress. The tumor suppressor proteins are able to regress this infection. But HIV is capable of progressing. So there are these antagonistic effects. Regression and progression. Regression is done by the tumor suppressor proteins. But the HIV inhibits these tumor suppressor proteins. And because of that, the cancer of the cervix becomes a reality. It would not have been a reality if the patient was immunocompetent. It becomes a reality because now the tumor suppressor proteins are being inhibited by HIV. Thank you very much. Thank you very much. Thank you very much. Bye-bye for now.